One.
Good day and welcome to a teaching video about non-invasive ventilation. I'm Dr. Vidya Lalu, and with me I've got Professor Andries Engelbrecht, and we are emergency physicians. So the reason that we are talking about non-invasive ventilation today is that we have got three novel devices that we are going to demonstrate. The reason for this is that during this coronavirus pandemic, we have had to source other manufacturers to make non-invasive ventilation machines, as our conventional ones have run out. One of which is even done by a car manufacturer. So as with anything with coronavirus, I must start off by telling you about personal protective equipment. I am not wearing any personal protective equipment for the sake of this video so that you can hear me clearly. But here's an example of exactly all the personal protective equipment that we need to have when using any of these devices. So Professor Engelbrecht has got on a hat, he's got double gloves, he's got a shield, he's got an N95 mask, over which you may put on a surgical mask and goggles as well. He's also got an apron and he's got boots on. This is full triple PPE. The patient in this scenario is actually just a healthy model who is helping us with demonstration purposes. If it was not so, she would also be on conventional oxygen delivery devices while setting up for the non-invasive ventilation. Alright, so the three devices we're going to be demonstrating today are the SafeP CPAP 100, which is this mounted on a stand. The second one is on this side, the CSIR Life device. And the third one is the UCL device, the University College of London device. So Prof is going to talk to us about the circuit that we use.
So I'm going to start off by talking about the circuit that we will be using for all three of these devices. We'll be using the same circuit for all three of these non-invasive ventilation devices. This is a simple circuit, and it starts off on this side with a pop-off valve. The pop-off valve is just a valve that is designed to ensure that the pressure inside the circuit doesn't exceed safe levels, so it will open up when the pressure increases beyond a certain pressure. The next valve is the anti-asphyxia valve, and that will allow the patient to entrain room air into the circuit to ensure that the patient always have an adequate supply of breathable gas. This connection here will be the connection that will be connecting to the three devices. For example, if I would demonstrate on the SafeP device or the CPAP 100, it will be going into that position, and the oxygen will then be delivered to the circuit from the ventilator. This is the circuit, and then we've got a T-piece connected into the circuit. This is a T-piece, and from the T-piece it is from the ventilator. On this side we have got a PEEP valve, so this will be actually the valve that will be administering the non-invasive mode of PEEP or CPAP in a spontaneously breathing patient. This is the all-important viral filter. We're dealing with COVID patients here, so we have to have a viral filter in our system that prevents the patient from spreading virus to the environment. And remember that non-invasive ventilation should ideally be administered in a negative pressure room. It's not always possible, but that is what we should be aiming for. And then of course we've got our non-invasive mask, which will be applied to the patient's face. This is our circuit that we'll be using on all three of our non-invasive ventilation devices. I'm going to go ahead now and I'm going to talk about the SafeP ventilator, which is one of these novel ventilators that might be distributed to hospitals by the Department of Health as a way to alleviate the shortage of non-invasive ventilators. So this is the SafeP non-invasive ventilator. As you can see, it is a very simple ventilator and easy to use. It's got only a few settings that we need to be able to change. This ventilator requires medical gas that is supplied from the wall. You can see that it's got an oxygen supply, and this is the oxygen tubing that's been plugged into the wall oxygen. and it's also got a medical air supply that has been plugged into the medical air port in the wall. So the SAFE-P device requires medical gas to be given. All three of our devices requires it, but the other two are entrainment devices in the sense that they don't need air. So they'll be entraining room air, but they will still be plugging into the oxygen from the wall. Okay, so as I demonstrated earlier, the first step will be to connect the ventilation circuit to the ventilator, and then I'm going to switch the device on. There's an on-off button here, and the device is now on. I'm going to ask my patient Tobile to remove her surgical mask and then to hold the non-invasive ventilation device on her face. Tobile, can you hold it against your face? Tobile, just breathe comfortably on this. How is it feeling? Feeling a little bit short of breath. It's common when we have got our flow setting only at 20 liters per minute that the patient might feel a little bit short of breath. So the first step that I'm going to do is I'm going to increase the flow to 30. How is this, Tobile? A little bit better. I can even increase it a little bit more just to make sure that she's really comfortable on this. So I'm going to be increasing my flow, and this is just, I'm going to be observing the patient. I must make sure that the patient has got adequate flow to breathe comfortably. If at any point the patient is struggling to breathe, I might have to increase my flow. Okay. I can also watch the anti-asphyxia valve. If the anti-asphyxia valve is constantly open, it means the patient is constantly struggling to get enough flow, and that might also be an indication that I must increase my flow. If I keep on increasing my flow, and I really can't get my patient comfortable on this device, it might be an indication that you need to escalate up to a different mode of non-invasive ventilation, a different device. It might be that this device is not the correct one to use on this patient, or alternatively that the patient might be so tachypneic that the patient might not be successfully ventilated with non-invasive ventilation, and the patient might require intubation and mechanical ventilation. Okay, the next step is going to, once my patient is comfortable, I will be observing the saturation on this patient, and I will be seeing if the patient is maintaining a good saturation. Depending on the parameters that you are aiming for in your specific facility, we know that in some facilities we are aiming for saturations as low as 85% and allowing permissive hypoxia. In other facilities, we are more aiming for saturations around 90%. So it all depends on what your local protocols is, and you strictly advise that you state your local critical care protocols within your hospital. So I'm going to observe this, and if Tobile's saturation is not at the level that I'm satisfied with, I'm going to change this button here. This is the FiO2. So at the moment it's on 21%, I can increase it to 30% or 40%. And often in COVID, I might need to increase it all the way to 100% because you know that these patients often require a very high FiO2. Once my patient is comfortable on the device and her saturation is at the level that I'm happy with, I can also then secure the device so that she doesn't have to hold on to it all the time. I can secure this earlier, especially if the patient is not as comfortable as Tobile is. So at any stage, I can secure this device and then carry on adjusting my non-invasive ventilation device. But this is just to demonstrate how these strategies are used. Tobile, if you feel comfortable, you can let go of the mask now. Okay, I think that is essentially the principles of using the SAFE-P or CPAP 100 device. What we're going to do now is I'm going to hand over to Vidya, and she is going to talk about the other device, which is an entrainment device that is being made by the CSIR.
Thank you, Prof. That was beautifully explained. And in fact, the principles that Prof has mentioned apply to the other two devices as well. So with the CSIR Life device, This device has an oxygen port, so this needs to be connected to the wall oxygen, but you will notice that there is no port for air to be connected. So what happens is that the room air is entrained into the device with the flow adjuster. So we've got 3 buttons. You can see an on-off button, which when it screws either tight, then it's off, or if it's loose, then it's on. You also have an FiO2 or percentage oxygen adjuster and your flow adjuster. So the principles are completely exactly the same as what Prof has mentioned already. Just remember that with this CSIR Life device, if you want to increase the FiO2, you need to increase the flow rate as well, as they are interdependent on each other. You also see the port where the device connects in. So if you use exactly the same circuit, and you can connect it and continue as you would. This device has a nice convenient little hook, so this can hang onto a drip stand for convenience. And that is as simple as it is. Just remember though, that with all of these devices, we don't have much experience because they are new devices on the market. And so if something goes wrong or you cannot figure something out, you can always revert back to your usual CPAP or non-invasive ventilation devices. And lastly, we'll be talking about the University College of London device.
Okay, so this is the University College of London device, and you can see that it actually looks very similar to the CSIR device. It's very convenient in that it's got a port that just directly plugs into the oxygen port or socket in the wall. This device then has got a on-off button, so I turn it open and then the device is switched on. I can then also adjust the flow by turning this knob and increase the flow that is delivered to the patient. So if the patient struggles or is not getting enough flow in the circuit, I will be increasing the flow. There is also an FiO2 button or a oxygen concentration button. This button is not calibrated, so I'll simply be turning it up to administer a higher concentration of oxygen. This feature here is the entrainment valve, and this actually entrains room air into this device to administer to the patient. The device works with exactly the same circuit as the other 2 devices, and it simply is plugged into this port. And again, we've got our anti-asphyxia valve, our pop-off valve, our ventilation circuit, our T-piece, our PEEP valve, our viral filter, and the mask that applies to the patient. The 2 oxygenation tools that all of these devices share is firstly the FiO2 button, and secondly it is the PEEP valve. The PEEP valve can be adjusted to increase the PEEP or CPAP, and it can basically be increased all the way up to 20. But often, if we get to those high levels, it might be the point where the patient actually requires a different or a more advanced ventilator, or actually requires mechanical intubation and mechanical ventilation. Thank you.
Thanks.